Dear colleagues, I'm Dr. Reza Nejad, the Chief of ACE2 Department at Bazargan Hospital, affiliated to Tehran Chamber of Commerce. I'm an anesthesiologist and Fellow of Critical Care Medicine. I was formerly an assistant professor at Shahid University of Medical Sciences. I'm going to discuss and review about coronavirus disease and the thing that we are encountering nowadays within our countries. It has spread, this virus has spread all over the world, and all medical personnel are involved in treating this deadly disease. I hope that this review would be of help for you, and I will suggest, with all due respect, 8 suggestions and 8 pathways just to reduce the mortality rate of the patients of this disease. Thank you very much. Today I'm going to start my talk in English about coronavirus. What does it do to our body? And then, with all due respect to my colleagues and the experts, suggest some points that might be helpful and useful for taking care of our patients. We are not unfamiliar with coronaviruses. They are circulating in our population for a long time, and we're familiar with them for about 50 to 60 years. They produce, or they induce, better to say, mild disease in our respiratory tract, and they come and go. But the thing that we are encountering with during these days, a very serious virus, which may end up in death of many patients. Coronavirus, the deadly one that we are encountering with during these days, belong to a family called Coronaviridae, and its subfamily is Coronaviridae, and the genus that these viruses belong to are alpha, beta, gamma, and delta. And within the beta coronavirus, we have SARS coronavirus, we have MERS coronavirus, and also the coronavirus its outbreak started in China in December 2019, belongs to beta coronavirus. It is very similar to SARS and MERS. These families are very similar to each other. Beta coronaviruses are very similar to each other. They're large and big viruses, RNA1 with envelope. Their replication is a unique process, belongs to these family. So WHO announced that SARS would be spreading in all parts of the world, and some measures established to stop this spreading. Another virus within this family called MERS, Middle East Respiratory Syndrome, started in Saudi Arabia, and it's transmitted from the virus responsible for this disease, transmitted from bat to camel and from camel to human beings. The most important point in these viruses: no remedy, no treatment, no vaccine. We do not have direct drug for stopping these viruses or killing these viruses. And they are insidiously circulate underneath our population. As I told you, the most important part is that there is any vaccine. The vaccine that was produced could not be effective enough, and because some neutralizing antibody could be produced in our body, and it could neutralize the vaccine that were injected. In December 2019, a new pneumonia occurred in China. The responsible agent or the cause was a virus belonging to coronavirus family. It was very similar, its clinical and pathological feature was very similar to SARS and MERS. For this reason, the World Health Organization called this disease COVID-19 and announced an emergency health problem all over the world. To prevent this disease, we need an urgent measure, just to bring this virus into check, with all the things and with all the drugs and with all the measures that we have in hand. A reduction in mortality in China and in Guangdong was achieved with early isolation of the patients, early diagnosis, and early management. Coronaviruses are a serious threat to our health system. And these big and large viruses produce many proteins. Some of them are structural and some of them are non-structural. Some of them are functional for the living of the virus and some of them are not functional but structural. The most important structural proteins in these viruses are protein M, N, E, and S. The most important of these proteins is protein S, which is responsible for the pathogenesis of the disease and the pathogenesis of the virus. Some of the viruses in coronavirus family also have hemagglutinin like influenza viruses. Both S and hemagglutinin proteins are responsible for the attachment of the virus to the host cells. Through its adherence to the host cell, the virus can inject its RNA into the cytoplasm and start its life cycle. And this is the S protein, the spike protein, that does it. The spike protein has two subunits, S1 and S2. S1 should attach to the receptor over the cell, and S2 has the responsibility to fuse the virus to the host cell. Where does the S1 attach? S1 attaches to a receptor over the cell. This receptor is ACE2, angiotensin converting enzyme 2. This is a protein over our cells. And this is a protein which belong to renin-angiotensin system. ACE2 can be found over the pneumocytes and over enterocytes, where these viruses, coronaviruses, attach. Not all cells have ACE2, so the cells can get rid of this virus easily. Accordingly, we will have respiratory disease and GI disease, gastrointestinal disease, when the virus invades us. The receptor for these viruses are not the same. In MERS, the virus attaches to its receptor, which is dipeptidase 4, not ACE2. This table shows us that the receptor for the coronavirus family are different. SARS is ACE2, and another coronavirus, NL63, is ACE2 too. And COVID-19, the disease that is spreading all over the world, the virus responsible for COVID-19 also uses ACE2. This is an electronic microscopic feature of the virus. Many of the viruses attach to the respiratory system. It is a false color. When the virus reaches the respiratory system, our DC cells, dendritic cells, which are in the first line of innate immunity, grab the virus through lectin receptor, because this virus S protein is a glycoprotein that can be attached to C-type lectin DC, a specific ICAM3. This is called DC sign. DC sign is a receptor lectin type that the virus attaches to it, and then the dendritic cells grab the virus, internalize it, and first, it should be processed the polypeptides of the virus should be processed and present to the MHC receptors over the adaptive immune system cells. But this is not done. Dendritic cells, when they have viruses, when they have coronavirus, they present it to the healthy susceptible cells and the neighboring of them. For this reason, the virus is spread from cell to cell and is not presented to the committed immune system cells. This is why this virus cannot stimulate our immune system to the degree that antibody and immunity occurs for our body. As I mentioned, the virus and the dendritic cells can collaborate with each other just to give the virus, just to transmit the virus to the susceptible neighboring cells, not to the committed immune cells. Virus entry into our cells is very important for the life cycle of the virus. And as I mentioned before in previous slides, the virus attaches to its receptor called ACE2. And when it attaches to the ACE2 through S or spike protein has got two units, S1 and S2. A cleavage occurs between S1 and S2, and S1 attaches to the receptor and S2 make the scene ready for the virus to fuse with the cell membrane. Coronavirus should enter into the cell, and after the life cycle is complete, some recombination occurs once again. We have S protein and 69 other proteins within this virus, and the vaccines are going to be produced against these proteins, but at the current time they are ineffective. Coronavirus 2, the virus that is responsible for COVID-19 disease, is very similar to SARS and is not very similar to MERS. As I told you, clinical and pathological features of these two viruses, SARS-CoV-2 and SARS-CoV, are similar to each other. And although some mutation has occurred for the SARS-CoV-2, the hydrophobicity and polarity of the parts mutated has not changed. For this reason, the clinical and pathological features, the life cycle of the two viruses, SARS-CoV and SARS-CoV-2, are very similar to each other. SARS-CoV-2 uses ACE2 as well as SARS-CoV. As I told you, pathological feature of the disease of COVID-19 is very similar to the disease caused by SARS. In lung tissue, there are bilateral diffuse alveolar damage with cellular fibromyxoid exudates. Hyaline membrane is scattered all over the lung, and this combination of pneumocytes occur. We have interstitial edema within the lung, and infiltration of immune system cells, dominantly T cells, can be seen within the pathological feature of disease. One of the most important part and important and key point in this disease is giant cells. Giant cells are assembly of several cells to each other that is produced by this virus. And this virus, when induced giant cell formation, it produces for itself a huge and big endoplasmic reticulum and Golgi system just to provide itself fundamental needs just to replicate. Do not forget the giant cell for the next slides. CD4 and CD8 T cells are deficient, but T helper 17 dominates within the lymphocytes that are circulating within our body when the disease occurs. In COVID-19, the overacting T cells are T helper 17. Do not forget giant cells and do not forget T helper 17 for the next slides. And this is the life cycle of the virus. The virus attaches to its receptor, and the receptor and the virus enter into the cell within an endosome, and within that endosome, depending on the pH within the endosome and cathepsin L, the virus can detach and inject its genome into the cytoplasm. Another way that the virus can enter into the cell is through mutual and collaborating work of a protease, serine protease, and the receptor ACE2. Within this collaboration, there is not any need that the virus and the receptor enter into an endosome, but the virus directly injects its genome into the cytoplasm. The first way of entering into the cell is dependent to the pH in the endosome and cathepsin L. This is where the drug hydroxychloroquine exerts its effect just to prevent the virus from replication. But the virus has another way of entering into the cell, depending on the protease serine protease. We're going to discuss some points about the receptor. The receptor of this virus is angiotensin converting enzyme 2, which belongs to the family or renin-angiotensin system. You know, this protein was discovered in 2000. And from that time on, we could find that angiotensin 2, the product of renin-angiotensin system, is not alone. It cannot do anything it wants to increase the blood pressure, to absorb salt, to do fibrosis, to induce apoptosis, and induce inflammation. ACE2 is an enzyme which converts angiotensin 2 to angiotensin 1,7. Angiotensin 1,7 has the responsibility to decrease the blood pressure, to prevent inflammatory cascades, and halt, or better to say, as a barrier to fibrosis and apoptosis. Here is another shape, another picture about ACE2. ACE2 converts angiotensin 2 to angiotensin 1,7 and angiotensin 1 to angiotensin 1,9, because ACE2 is monocarboxypeptidase or carboxymonopeptidase. It is very important that get familiar with angiotensin 2 because it induces inflammation, induces apoptosis. And in mice, whenever renin-angiotensin pathway is blocked, or whenever catalytic active recombinant human ACE2 protein come into the scene, the ARDS process or pathway is attenuated. So, angiotensin 2 aggravates ARDS and ACE2 attenuate ARDS. And for another experiment, it was demonstrated in animal studies that mesenchymal stem cells that could express ACE2 could attenuate ARDS process. So we have reached to a point that ACE2 protects against acute respiratory distress syndrome. And in ACE2 knockout mice, it could be seen that ARDS process is aggravated whenever lipopolysaccharides, for the sake of sepsis, and acid aspiration induces ARDS in the lung. Acid aspiration results in ARDS, and lipopolysaccharides from the bacteria also induces ARDS. And in contrast to ACE2, angiotensin converting enzyme could aggravate ARDS as well. Treatment with human recombinant ACE2 can attenuate ARDS process. I'm going to discuss something else within this film about influenza as well. Influenza H5N1 can produce, or better to say, can induce ARDS process. The receptor is once again is ACE2. And in H7N9 as well, the receptor is ACE2. And these influenza viruses also induce ARDS phenomena or process in our lung. And the cause of death in COVID-19, in SARS, in MERS, in influenza H5N1, influenza H7N9, or all adult respiratory or acute respiratory distress syndrome. In influenza from H5N1 and H7N9, ACE2 deficiency, acute respiratory distress syndrome in mice. In these diseases, the level of angiotensin II is high. And the level of angiotensin II is linked to the severity of the illness. And it predicts the fatal outcome of the disease. Okay, we can find another thing, that angiotensin II level is very important in fatal outcome of the diseases of influenza and COVID-19 and SARS. Because ACE2 is very important, and we have deficiency of ACE2 in these diseases. Why the deficiency? This is the molecule of ACE2, and this is receptor binding domain of SARS-CoV, which is very similar to SARS-CoV-2. Apart from this part, which is called receptor binding motif. The receptor binding motif of COVID-19 virus is different and mutated in comparison with SARS-CoV. In SARS-CoV-2, in COVID-19 disease, this receptor binding motif has got more affinity to attach to the molecule of ACE2, increased affinity. Here is a thing that I want to emphasize and notify for our colleagues. There is a zinc within the molecule of ACE2, and ACE2 is a metallopeptidase. Please do not prescribe zinc to patients with COVID-19. It might be harmful and hazardous, because ACE2, the receptor for the virus, needs zinc. And here is another slide to show the life cycle of the virus as I mentioned to you. ACE2 is the receptor, virus attaches to the receptor, it is uptaken within an endosome, and cathepsin L helps the virus to inject its genome to the cytoplasm. And here's another way that virus can enter into the cell through a collaborative effect of angiotensin converting enzyme to the receptor and transmembrane serine proteases. Transmembrane serine proteases are co-expressed with angiotensin converting enzyme 2, the receptor of virus. So they are residing over the cell membrane in very close contact. What do we have? We have reached into a point that we have encountered a virus, a deadly virus, that we should do anything we can do in a short time and immediately to bring this virus into the check. We cannot let the virus spread. If the virus spread, many people may die. And we know that the virus needs to reach to the lower respiratory tract. We know that the virus can enter into the bronchial cells, ciliated bronchial cells, and alveolar cells through a receptor. And we do know that the receptor belongs to the renin-angiotensin system. And we do know that angiotensin II can provoke inflammatory reactions and aggravate ARDS. And we do know another thing, that the virus hires our proteases to make it replicate. Okay, what the heck? What can we do? Some suggestions to the experts, with all due respect to my colleagues and the other scientists all over the world. We can use, if it is possible, recombinant human ACE2, soluble form, just to circulate within our circulation and to entrap the circulating virus, although they are rare. Infective virus can be found rarely in our circulation. They can be found more in the mucous membranes and the bronchial tree and the alveolar cells. Although the virus can be found within the urine. So when it can be found within the urine, it should have some circulation within our blood circulation. Another thing that, although in MERS, inhaled interferon gamma was not successful, we have something in our hand. We have recombinant human ACE2 soluble form. When it is injected into the circulation, it can entrap any infective virus has come into the circulation, although it is rare. Infective virus is rarely found within the circulation. Instead, we can find RNA of the virus. And RNA of the virus within the circulation is the backbone of the test, PCR test, that can find RNA of the virus within the circulation. This test is not sensitive enough. Please remind that this test is not sensitive enough. Okay, recombinant human ACE2 soluble form can entrap infective virus and not let it to infect other cells. Interferon gamma, the inhaled form, has been used for patients with tuberculosis. It can induce dendritic cells and macrophages to phagocyte the virus and present it to the adaptive immune system cells, instead of giving and present it to the susceptible, healthy neighboring cells. But in MERS, it was not effective. We have zinc chelating agents. Could you remember, and I would like you to remind that within the ACE molecule, there was a zinc atom. The zinc atom is very important in this metallopeptidase. If we use zinc chelating agents, we can suppress the activity of the receptor so the virus cannot attach to the receptor. And another suggestion, we have anti-angiotensin II receptor agents like losartan, valsartan, and we can use them. I will discuss it in the next slide about anti-angiotensin II receptor. We have a mixture of insulin and glucose in hand. Insulin protects mitochondria from producing reactive oxygen species or free radicals, and glucose helps with insulin help mitochondria produce as much as energy it can without harming mitochondria. Within these diseases, influenza and COVID19 and SARS, a basic part is mitochondrial dysfunction. It will be discussed in other sessions. I will discuss about them. And we have also aerosolized antiproteases to suppress transmembrane serine proteases that could help virus enter into the cell. We have also systemic antiprotease. And because antiprotease, transmembrane serine protease are not vitally important for the cells, we can use easily these antiproteases for the sake of not letting a virus to enter into the cell. We may have anti-lectin products just to prevent the virus from attaching into the dendritic cells. Okay, we have ARDS in this disease that is the cause of death of the patients. In ARDS, we have marked increase in lung tissue, massive loss of oxygen in our respiratory system, and the thing that is the characteristic feature of the ARDS, lower lobes non-aerated and upper lobes aerated, despite substantial increase in regional lung tissue. Okay, we can go to another slide. This is the characteristic features of CT scan in these patients, and ARDS type 1. We have mixed and diverse pattern in the parenchyma of the lung. We have opacities, we have ground glass opacities, we have consolidation within the lung. Just exactly the characteristics of ARDS. But there is something different as I encounter the patients with COVID-19 disease, that although the chest X-ray and CT scans are very, very bad and very destructed lung, O2 saturation is not so low, and suddenly it goes down and plummeted and sharply in low condition that the patient die from hypoxia. We have a case report here just to show you that a remedy I used for one of my patients and the changes in the behavior of the disease and pathological feature of the disease. A 40-year-old man referred with fever and muscular pain in March the 5th. CT scan showed a consolidation in his left lung field, very small, but it was ignored. The patient went home for 4 days. Within these 4 days, he had fever. He had still fever. And in the 4th day, he came back to the hospital and another CT was done for him. This is the feature of his CT. You can see the opacity in both lungs with consolidation in the left lung field. This is an axial view of a CT scan in March 5th. An axial view in March 5th. And a sagittal view with where the consolidation can be seen here, and prebronchial consolidation and infiltration. Here's his CT scan axial view in March 7th. You see that the opacity of the lung has attenuated, though the lesion has expanded, but we can see air bronchogram within the lesion, and it shows that the lesion is resolving. Go back to March the 5th CT scan. You can see consolidation is so packed. It's very consolidated. And in March 7th, it is in the resolving process. Here is the sagittal view of March the 7th CT scan of this patient. You can see although the lesion has expanded, you can see air bronchogram within that. And the resolution of the consolidation or prebronchial infiltration around this bronchus. Okay, I used Hansfield unit for describing the CT scan of this patient. In March the 2nd, in March 2, you can see the axial view of this patient. Although you cannot see the consolidation that resided in this area, but the Hansfield unit, average or mean Hansfield unit or CT number is about minus 846. What is Hansfield unit? It is a unit that is measured for the pixel attenuation in the CT scan. When the CT scan of the lung is done and air predominates against or compared to the lung tissue, and better to say, in the Hansfield unit of air is minus 1000. Whenever the number reaches to minus 1000, it shows that the air dominates in the lung field. And whenever it reaches or go to 0, it shows that lung tissue dominates and no air. So in ARDS we had aerated part, non-aerated part, lung tissue and air alveoli, air-filled alveoli. We logically would like for a lung field to have Hansfield unit of near minus 1000. Okay, in March the 2nd, the Hansfield of mean Hansfield number of right lung of this patient was minus 846. Okay, in March the 5th, Hansfield declined to, or better to say, reached more near to 0, minus 721. Here you can see the opacity of the right lung has increased. And you can see the lesion in the left lung. The mean Hansfield is minus 721. We started losartan plus glucose, insulin, potassium for the patient in association with 4 antiviral regimen, drug regimen, as the protocol, national protocol in Iran. But we just added losartan and GIK to this patient. Let's see what happened. After 2 days of losartan and GIK in association with 4 antiviral drug regimen, we reached to this CT scan. The CT scan, exactly the same level of the CT scan, but in March the 7th, you can find the Hansfield unit is minus 847. It is going to reach to minus 1000. It shows that the aerated alveoli has increased. And infiltration of the immune system cells and the edema of the lung tissue has decreased. So we have got something. Losartan could give us a remedy to increase the aerated part of the lung, or better to say, to decrease or attenuate ARDS process. Once again, you can see the opacity of the right lung in this patient. The right lung was not involved in this CT scan. In the CT scan, 2 days after starting of losartan and GIK, the opacity decreased and aerated area increased. So, we discontinued losartan for one reason. Because in some articles, it is said, it is demonstrated that losartan might increase ACE2, and increasing in ACE2 content of the cells might increase the receptor of the virus and viral load of the respiratory system. But it might not occur. I will discuss it more in the next slides. So we discontinued losartan on the second day of treating the patient. What happened? 3 days after cessation of losartan, this is the lung of our patient. There is another consolidation developed here in the right lung, and we didn't have any development of the consolidation within the 2 days of starting losartan. And after 3 days of cessation of losartan, we can have another consolidation here, and the opacity of the right lung increased. What is the Hounsfield unit here? The mean Hounsfield unit is -798. It shows that aerated area has decreased, and lung tissue and edema and infiltration of cells has increased. Losartan started once again, and currently we do not have a new CT scan, and I will order for it, and I will show it once again in another film that will be produced in a few days later. Once again, I would like to review because it is very important. We have a patient, 41-year-old, and the Hounsfield unit of the lung, when he was suspected to have coronavirus, was -846. And 4 days after he was suffering from cough and fever, when I encountered the patient, the CT scan showed that Hounsfield unit mean CT number was -721. This is the first day. This is the second day. And this is the day that we started losartan plus GIK. And after 2 days of losartan, Hounsfield unit decreased to -847. This decline in the Hounsfield unit is very good for the patient because aerated area increased and lung tissue and edema decreased. We discontinued losartan, but 4 antiviral drug regimen and GIK continued. After 3 days of discontinuation of losartan, we have another CT scan. Hounsfield unit increased to -798. It shows that opacity of the right lung increased. It shows that interstitial edema, lung tissue infiltration is increased. And another thing that within these 3 days, another consolidation developed. You could see that with losartan, the ARDS could be attenuated. I would like to discuss something very important about losartan. Nowadays, every expert around the world talk about COVID-19. They suggest every day and in hourly manner new advice to the literature. Losartan is an anti-angiotensin II receptor. It can increase ACE2, the receptor of the virus. So you can tell me that, why you used losartan, because it increases ACE2 content of the cells. So it can increase the viral load to the body, but it doesn't occur. You know, similar to HIV, that increase its infective power by decreasing or downregulating its receptor called chemokine receptor 5. In a process called abortive infection, it seems that COVID-19 disease has the same similarity, has the same effect. SARS-CoV-2 itself downregulates ACE2. And this downregulation increases and gives the scene to angiotensin II to increase its apoptotic, inflammatory, and all the hazardous effects to the respiratory system. So if you start prescribing losartan to decrease angiotensin II, what happens? The balance between angiotensin II and angiotensin converting 2, enzyme 2, ACE2, once again is regulated. And for this reason, according to my patient, that it shows that losartan could reduce the opacity of the lung. It shows that losartan can do. During these days, a new drug, tocilizumab, which is Actemra, produced by Roche, has been virally talked about because it is a monoclonal anti-interleukin-6 receptor. During these days, a drug which has been used in rheumatoid arthritis, juvenile rheumatoid arthritis, is virally talked about around the world. In China, it was tested and it decreased the opacity of the lung of the patients. Could you remind that I emphasized and notified the giant cells and T helper 17? It seems that according to our understanding that the patient's CT scan or chest X-ray is not consistent with autosaturation. Chest X-ray and CT scans are very destructed, but autosaturation is good. It seems that much more than can be expected of giant cells are produced. Giant cells are the pool of the virus. It has a large endoplasmic reticulum and very vast Golgi system. Okay, what happens that these giant cells are produced, are built? This is interleukin-6. Interleukin-6 is a cytokine that is produced in inflammatory cascades. Angiotensin II induces production of interleukin-6. And interleukin-6, when it attaches to its receptor, interleukin-6 receptor, it induces a pathway that is very vast. Within this pathway, we can have JAK2 STAT3 pathway. JAK2 STAT3 pathway, through producing BCL2, it prevents apoptosis and helps the cells to gather together and produce giant cells. It's a theory. And these giant cells are pool of the virus. If we break the pathway of angiotensin II, interleukin-6 receptor, and the downstream pathways of JAK2 STAT3, we can break the production of giant cells. And another thing, that interleukin-6 induces T helper 17 as well. So we can see that this is angiotensin II and then interleukin-6 that make the scene ready for ARDS. For the proof of my theory is the drug Actemra or tocilizumab that is virally talked about. It is an anti-interleukin 6 receptor, and it could reduce the capacity of the lung in some patients. But you can see that this drug is very expensive, and this drug might have some very serious side effects. For the time being, I'm not going to discuss about interleukin 6 more, but I would like you to think about losartan, why it cannot be used because of ACE2 overexpression. It is not the theory that can be proven. The thing that is important that is COVID-19 is a deadly disease, a serious disease, that if we cannot bring it into a halt, it can, many people would die. I would like here to thank Dr. Iravanamanish, the chief of the hospital, and Dr. Hamid Sattori, Deputy of Therapeutics, who always support us and provide us with all the needs and with all the equipment and demanded facilities to overcome the diseases, to treat our patients. And I would like to thank Tehran Chamber of Commerce to provide and make the scene ready for recording these educational clips. Thank you. You can find me through my email, ask me any question, or we can discuss mutually with each other. Thank you.